grab my bicep, and then I pulled her this way.
Right.
And then I had her do her genie arms, and I put my arm through here.
What kind of arms?
Genie
Oh, okay. Okay.
But now I'm kind of, well, I would want to have my hands in the location where I thought her pain, like the joint. And I'm using my distal arm to help me put her into more extension by pulling her this way. Is that correct?
Rotation.
Rotation.
You're doing a little more rotation than anything. So now there's your force couple. So you've got your pressure's going to be this way, and so then you're working through your trunk to apply the pressure. All right. So you're not working here with your hands very much. You just kind of put them in place, but then all the action is really coming through here, like so. All right. One thing you can try to add a little bit for leg position. All that looked fine. If you hook the top leg kind of here, and then what sometimes I'll do is I'll get kind of the front of my thigh on top of the knee here. It just gives me a little more leverage. So I can come in here, and I come here, and now I've got so I'm working through my trunk, and then I got my weight down on the leg here. And so it just gives me a little longer lever arm to work through. And especially people that are much taller than you are, people that are generally more mobile, it's harder to get them to end range, and I think this helps get them to end range. So I really kind of have to get on top of that knee, and then I get some more leverage that way. Okay? So try the top leg, kind of hook like this, and see if you can get some leverage through the side of that knee.
Right in here. And then I would say, okay, because I'm just going to be kind of going down like this. Okay, so go ahead and, oh, okay. Like this maybe? Too much. Okay, so go ahead and breathe in. Is there anything you missed?
Like you make the...
Take another nice deep breath. Exhale. I'm going to do the manipulation of the exhale if that's okay. I was already like getting fatigued holding it, and I don't think I can.
So have the patient exhale, nice easy breath in. Exhale. And just take up the slack. Get a sense where end range is.
I'm gonna
close. Yeah, I'll rotate her.
Oh, yeah.
You were thinking.
Oh, yeah. Actually, I didn't hear
It feels like I need to
Yeah, you can. Oh, yeah.
It's harder with former dancers who are more flexible.
Kind of like this. All right. And then go ahead and breathe. And breathe in. I'm going to do another exhale. Exhale.
I think it was just somewhere to do.
I don't know. Someone can do it on me. Sure. Okay. So I just screw you over first.
The table, okay.
Just
let me know, because I can adjust.
This leg.
I'm trying to figure out. I'm trying to see if I know how to do it.
Perfect, right there. Okay, now I'm going to have you make knee arms.
I was thinking like after this.
So her knee's already like up on my hip.
After you've done this, then when Adam's doing here, so what do you guys call this one?
SI classic.
Oh yeah.
The classic, or somebody said the smiley face?
Oh,
All right, so then try this one.
It, like,
I maybe should have like kept going with your legs.
okay, one more time.
Do this. Couldn't get anything out of it.
Smile all the way.
You know, there's and that's how
I'm not rich. I can't do it
Yeah.
any faster.
It was
more specific.
I don't bend that way.
Research that you'll come back to.
table adjustment. Of course, yeah. You know how when it gets so close that like you start to feel it, but it doesn't go in? But it's
You guys, a couple of questions have come up here in terms of how specific and your hand position and thumb position. You know, the more localized you can make it to the lower lumbar area, that's really where you're trying to affect change, the better. But you know, I would not spend much energy worrying about are you feeling it move, or you know, am I at the get in the position and do it. Yeah, really, that's what I would do it. So, well, you don't want to rip things multiple times, but as long as you get into this position and you have your, your hands generally in the right position here, then, when I rotate back, am I really feeling for when it moves? Well, maybe, but it's not necessary. It's not necessary. Okay. So for the classic, and do you want to show the position from the start? Maybe it's great. Okay, so is this another alternative? Somebody doesn't tolerate that sideline position with all the rotation.
That side of the table. Go over this. Come underneath. Like this. This.
That was so very short, yeah. Yeah, we should be doing this with our
Okay.
shirts off.
When does it smile away? Is it always towards like that?
I think it's
Smile away, because then you would hook the leg.
smiling at you.
So you want to rotate in the same direction to side bending or the opposite? Opposite.
So then that was just a side bend and rotate same, wasn't it?
Correct. It was.
Okay, so you have to smile away, rotate towards.
Correct.
Okay.
Come towards.
Oh, smile.
Oh, gosh.
That's when you're over and up at the same.
And then rotate just like you did.
Yeah,
Just like you did. Yes.
Should we go in?
Okay.
One more time. You look nice and it's like such a stretch. Oh my gosh.
You just
Just
can't
like the position set up is like like
Yeah.
this.
Oh, yeah. Okay.
Cross this leg over. Can I have you cross your arms like this? And I'm just going to hold you up and turn you, okay? Oops. And then I would want to do it like.
careful with your pressure over the ASIS. Like get a little uncomfortable for some people. Just try not to dig in. And again, you can always put like a washcloth or a pillowcase over that and that can help.
And then I would. How do you go like this?
There you go.
There.
Shoot.
Oh, so I just hold it here, but I'm going like that.
Yeah, it's really just that.
That's okay. I'll just pretend. And then is this tender for you?
I'm just gonna.
So just go like that.
That's the point.
And I never got anyone to cavitate on this.
Give me like that. This part, and you keep kind of rolling me over.
Someone can.
And then you use your body.
Yeah, because that's what I felt like. Okay. So first I'm gonna have you scoot it towards me.
Oh yeah.
Yeah.
I can.
Because that's really good.
You need it like one.
And then I'm gonna charge for your
No, that
your head. Okay. Your neck.
Let it hop.
Okay.
Yeah.
And then, okay, how do I?
Sure.
Yes. But I don't know if that was
I would just hold. So then you have it direct. You just hold with your hand.
Yep. There you go.
So then when you're
And all you're doing is you just weight shift her back, and she'll come along with your eye.
Okay. And then
Oh, yeah. Yep.
exhale.
The T-spine? T-spine.
Okay, one more time, and I'm gonna this one.
That felt good.
That's the idea.
It felt good. Yeah, it
I
did.
like doing a little quicker.
Yeah.
This hand is getting tired.
I could tell
Little
that you're
espresso.
making-
My left hand is iffy. It doesn't like cardio.
And this is my favorite part.
Who wants to be my sponsor?
Oh, I can be your
Their
spot.
favorite days.
Oh, I was just telling Kyle that I just went to manual therapy like an hour. Straight on. So they wanted to say,
There we go for Teresa. This is like not really screwed on.
oh yeah.
Just for the reason.
Can you okay right there?
I don't pop that way.
This thing is gonna fall right off. There we go.
Anything else you want to review or practice in
It's
terms
not really
of
screwed
pelvic
on.
pelvic stuff?
You better do this one now. Oh, do it.
Okay, so sacroiliac joint, if it's the pain generator, the pain will not be central. It will not be central pain, whether it's sacral or lumbar pain. It's going to be left or right side, and you can get pain referral down into the leg, and sometimes even below the knee. So it is, yes, you can get referral down. That looks good.
You're asleep over there.
That's all right. I mean, cavitation is nice, because people always say, oh, I needed that. Well, then they needed it. All right. Anything else on your list? You're comfortable with slump sit, turning that into treatment? Yeah, you know, I think neuromobilization, neuromobs, that's a tissue that you can stir things up fast. It can be overdone really easily, and so I'm much more conservative in terms of, you know, how many times I do it in the clinic the first time, and when I have the patient, you know, when I make it clear to them, you know, these are the numbers you need to file until you come back next time. Okay, how good it may feel. I don't want you doing more than I'm giving you here until you come back next time. Flossing is less stressful, mechanically stressful. So oftentimes that's where I'll start before. The more chronic they are, then the less flossing I do. Having just said what I said, the more acute they are, then the more flossing I'm going to do. Or, you know, for example, this guy here, he may not be ready for neuromobilization related to the left lower extremity, but I might have him do it with the right leg, even though his straight leg raise is normal there. I may have him do head and neck flexion, ankle dorsiflexion on the right leg, just to gently stress the left side, maybe. It just depends on how successful I was with the other things that we talked about. You're going to have some people where you do straight leg raise, and that gives them that sharp wire pain on the back of the leg, and then you add head and neck flexion, and they feel better. It'll be worse, they feel better. Right? And that's somebody, again, that's more chronic, not acute. So when that happens, that's a positive sign. They need neuromobilization. And so one of the things I'll do, maybe I'll go eyes. And I can keep down at this end here. With hands underneath his head. So let's say on the right, so that, we get to 45 degrees, kind of a sharp wire sensation down back of that leg. And you've been stretching your hamstrings like crazy for the last 6 months, and you're not getting better, you're getting actually a little bit worse. So I come up to here, there's that, again, hot wire. I'm going to back out, let me know when that pain goes away. I back off a little bit, it's gone. Okay, come back up to that point, now lift your head and hands up off the table. Oh, that's better, and I have more range. Okay, put your head back down. So how we're going to neuromobilize is we're going to come up together. So bring your head up, and I stretch. Put your head down. So it's kind of flossing, but I'm adding more tension from the top down. And then this is what she's going to do for home program. So I use head and neck flexion for her to better tolerate directly. Now I'm stretching. There's no flossing here. I'm stretching. And one of the theories behind this is, let's say you had some scarring around a nerve root, or you have a big osteophyte down here, and a nerve root is irritated some, and so when you do straight leg raise, the irritated part of the nerve gets pulled under that osteophyte, or it yanks on the scar tissue. All right, and now with head and neck flexion, so now tension's coming from this way, it pulls that irritated nerve root out from underneath that osteophyte, or it puts less stretch on the scar tissue. So it's a scar tissue so it's more extraneural as opposed to intraneural. And it's unusual, but it's not rare. So don't assume head and neck flexion is going to make them worse. So the question always is, lift your head and hands up, does that change it better or worse? And you can find times where it gets better, and then you can use that. Because it may be too painful, for me to directly mobilize like this without the head and neck flexion. Because again, it's a sharp pain. When I add head and neck flexion, it's more of a stretch sensation, and it's a softer end feel. So that's how I'm going to stretch her with the head and neck flexion. And at home, what I have people do at home for this is they lie in a doorway, and this leg is inside the door, and the heel is up on the door frame, and you scoot your butt as close as you can to the door, and the knees flex to start with. And then, let's see, put your right hand here, and left hand there, and then, okay, I want you to slowly straighten out your knee and lift your head up, and then back down. And repeat that. This is the way they get self-mobilized. Okay?
When you are assessing, did you have her do the head up first? Or you found the angle of the first straight leg raise, and then did you have her do head first and then leg, or?
No, usually what I'll do is, this will be the sequence. So I do the straight leg raise first, and I get that nerve type of sensation. And so I back off, and I want to know when the pain goes away. Because the faster it goes away, and sometimes, you've seen, I'm sure, some of the other your classmates, you back off a couple of degrees, it's gone. So it's like a light switch going on and off. That's tissue that's ready to be stretched. If I bring the leg up to here, and I get that hot wire, I'm going to lower your leg, let me know when that pain eases up, and it's down to here before it starts easing up, that's more acute. And I'm more likely to flare them up by stretching at this point in time. But if I come up, it's on, off, that tissue's ready to be stretched. Now, if I add head neck flexion, then I'll do head neck flexion next and see what that does here. If it increases the pain, then then this would be too aggressive. But if they get relief, and I get more range, then that's how we're going to mobilize the nervous system on this side. And again, thinking it's more of an extraneural limiter in terms of the extensibility here than intraneural.
So head neck function is too aggressive, and you just do tugging one end,
Right.
like your typical
Right.
neural.
That's right. Yeah. So especially with more chronic issues, that's what people who are truly acute, they're not going to get relief when they flex head. People with long-standing problems, and they'll come in, it'll be hamstring strain is what it's going to be. But the more they talk, the more it sounds like this is sciatica. And so the more chronic people is when you're more likely to run into that situation. Okay? But you'll make big gains by doing it together, the head neck flexion with the straight leg raise. All right. Did this guy need an MRI? No. Not at this stage. Even a week ago, when he had symptoms below the knee, but it was an ache and sharper pain. If he had frank weakness, then you can probably make a case for an MRI. But that's really all. This soon after the onset. So he did not need an MRI. This was a guy I saw a few years ago. And I finally convinced him at the end of that first visit that, and call the doctor with the MRI, but tell the MRI, no matter what they see, it's not going to change what we do. You're already getting better.
Did you treat his ankle?
I did for him. And he had a full load of driving coming up. I really worked hard at stretching out that hip, and he tolerated the lumbar roll pretty well. There are people who, with fairly flat back and have much of a lordosis, they're not going to tolerate much of a lumbar. They won't tolerate a lumbar roll. They may tolerate a lumbar cushion, but the roll, especially the full rolls, a lot of people don't tolerate it. It's too much. It's like having three arch supports when you only need one, in your shoe. So there's times where I just loosely roll up a towel, and it's more there to remind them, I don't want you doing this. I want you to stay more up here. But if you force them all the way to the end of their able range, it's like having your finger cranked back here. No one's going to like this for very long. So a lot of people don't tolerate the roll, the full roll. You've seen Not a Chair? Mm-hmm. Yeah, I wish I had stock in a company, because I recommend that a ton for people who sit. I don't care what kind of chair they have. Sometimes people get upset because they spent hundreds and hundreds of dollars on a nice office chair, but all their work brings them this way. They're not using the back of the chair at all. And then I have them buy the $60 thing, and now it's sitting in the rate. So they're all upset they spent all that money on that chair. So when I could use not a chair, I tell them I don't want you sitting back in a chair. I want you sitting up more toward the edge. And the fact that they can adjust it, you can add more support, a little less support. That's a really cool device. One of the best inventions in the last 30 years, and you don't plug it into anything. And they hold up well. I've had some physically big people who, and it's lasted years and years. And they can travel with it easily, which also is really nice. All right. Thanks for coming this morning. Thank you. If we can put all the orthotic stuff back up on the table, that was there when we came in.
Got it. Want to sit around?